I'm calling the meeting to order. Can you please do roll call?
So Dr. Bombard.
I'm here.
Dr. Broderick.
Here.
Dr. Daly. Dr. Durso.
Here.
Dr. Fern.
I saw her.
It looks like she's here. I'll skip for now. Dr. George. Let's see. Dr. Gerling.
I saw Dr. Gerling.
He is here.
Dr. Katz.
Yep, I'm here.
And I'm here as well.
Great.
All right,
Yes.
thank you. Dr. Laporte.
Yep, there we go.
Don't see him. Dr. Mulvey. See. Dr. Pond.
Here.
Dr. Williams.
Here.
Patty Bashaw.
Here.
And Tammy Tromley.
All right. I know we all got the old minutes. Could I have a motion to approve the minutes?
So moved. That's Broderick.
Thank you.
Seconded.
Excellent. And I think the next part is the CMAC report, yes? I apologize, I'm moving screens here. I'm opening up my CMAC report for you. Okay. We had a CMAC meeting December 4th at the Hilton Garden Inn in Troy. There was not a lot of reportable stuff, really. Med standards, talked about a BLS glucagon pilot for Suffolk County that I'm sure if you're interested in doing a BLS glucagon pilot, you could hop in there with them. For the CMAC, we talked about the Surge Operations Center is still in effect. So this is an operations center where you can report if there's long wait times or if there's problems at hospitals with like boarding for weeks and weeks and so on. They're supposed to help with distribution of patients in some way, shape, or form. I'm not sure how pertinent this is really to us here in the North Country, but they were for a while helping with transport from hospital to hospital. This is sort of interesting and exciting. The Bureau of EMS is going to take over the blood transfusion regulation from the Wadsworth. It sounds like that's going to be at least a partnership because I can't imagine the Wadsworth giving all of that up, but that will become very important to us because ground transported blood products was approved. The regulation for that is in the process of taking shape, but at some point, all of us are going to have a very exciting meeting or two trying to figure out how we're going to do that. Because certainly we're not going to be able to equip every ambulance in our area with blood products. So then choosing which ambulances will carry them and which will not will be an adventure, I think, that we'll all take together. The February CMAC meeting is this week. So stay tuned for that. If there's anything timely from that, obviously I'll email you. That is about all that's really pertinent to us as a REMAC. There's a bunch of REMSCO kind of pertinent stuff, but not so much for us. Okay. John, do you have a SEMSCO report?
Pretty much everything that you just said. They did say timeline on the blood products was still probably going to be a year out before the regs are written and vetted and all of that wonderful state bureaucracy side of things. But everything else really is more REMSCO related regarding that. So that's all I have to say.
I didn't see a Department of Health rep yet. Did you?
Vinny is the only one who is able to be here, and he's doing an interview for an investigation That was at 2 o'clock. His goal was to be here by 2:30 if we were still meeting, and he would give a report. Other than that, he doesn't have a lot to report on other than Alex and him are splitting the region still and trying to give as much coverage they can. And he's got about 18 investigations going on right now throughout the complete central New York area and up into the Adirondacks.
Wow. Do you know if they're talking about like giving us a real area rep again? I haven't heard anything one way or the other.
And that's what Vinny was actually supposed to be. And then they moved Melissa Lockwood to the education side of the house. And that restructured the Syracuse office. So we're in limbo again.
Okay. All right. I think we're at a program agency report already.
Okay. Really not a whole lot. I mean, I sent it out to everybody. If they have questions about anything, let me know. The CQI initiative is still going well. We're getting great feedback from the docs that we do interact with. Dr. Pond was one of our more recent ones where we were like, hey, can we talk to you about something? I don't know. He can speak to it if he thought the process was valuable, but we're finding some good things out of it. And we're actually starting to now see some results out of things. And then, you know, that cycle of everything starts to get better. And then all of a sudden they start doing the same things over and over again. And I can let Amanda speak a little bit more because it's her baby.
So still the big things are spelling and grammar. Some charts are absolutely horrendous when it comes to spelling. Lack of focus assessments. There's been a big thing we've noticed lately where providers aren't taking vital signs until the patient gets to the ambulance. And unfortunately, in the charts that I've noticed it in, they have been critical patients who should have had interventions way earlier. So that's about it that I've noticed.
What's it? We should talk about this later in the meeting as well, but just to prompt me later, maybe that's something that we could think about as a regional initiative if people are interested, like within our smaller QA groups. Because I've been running into that as well when I'm personally QAing charts that people, newer providers particularly, are not taking vital signs on the scene, and then they're kind of surprised by these unstable patients that they would not have been surprised at if they figured out while the patient was still on the couch that their blood pressure was 60. So agreed.
You're absolutely right.
Yeah, I'm seeing that too. All right. Agency operating authority renewals. We have Queensbury, Granville, Ticonderoga, Saranac, Morrisonville, Lake Placid, and Rouse's Point. I know Dr. Mulvey is not here, but I know she does not have concerns about Ticonderoga, so I can speak to that. But anybody else have any concerns about the 2-year renewals for your agencies?
No concerns on my part. This is Doug Gerling, Queensbury, Granville, all running well. I've no problems. So unless anyone else has a reason why they should not be renewed, speak now or forever hold your peace.
Agreed. Saranac Fire District is still doing a very small number of calls, but doing fine. Morrisonville, Dr. Furin, all okay over there?
Yeah, no concerns.
Great. And Lake Placid, Dr. Pond?
That's fine. No problems.
Great. And Rouse's Point, Dr. Durso. I know Mike's at work, so.
I'm still here for the next few minutes, but I am heading in soon. No
figured.
concern for Rouse's Point. No,
Great.
they're a small crew, but they're busy enough.
Fair enough. Awesome. Yeah, you guys are doing some high acuity stuff up there I've been seeing coming in. Good deal. All right, QAQI. Alice Hyde, Scott Harwood, I saw you here. What's going on up there?
Hi, Jeff. Yeah, we have a plan, as you know, and we are working on scheduling a meeting for the that'll be inclusive of both BLS and ALS agencies. Pretty soon, we're trying to align those with our normal county meetings. So we're working on that. And then I know there's a lot of agency level QI going on as well.
Great. I can't see if Storm is here.
I am.
Yay. Hi, Storm.
Hey, so we realigned our QI meetings with our advisory meeting. So we're meeting first as a QI group, and then we'll meet afterwards as a advisory. So people only had to be out one night a month instead of twice a month, because most of them are the same people. And we're still working on how we're going to get data fed to us in a way that makes sense so that we can do it. We are going to look, however, at cardiac arrests and cardiac saves for the last 3 months and see what we can come to grips with that. And then we'll pick another project probably in, let's see, we met in February, so it will be March. We'll pick another topic.
Okay.
So where are we at?
Awesome. ECH, I saw Patty. Hi, Patty.
I am. Hi. So we are meeting quarterly and pretty actively meeting. One of the things we're checking on are a lot like what Amanda's doing. Do we have any open PCRs that aren't getting submitted? If they aren't submitted, then we can actually go into their programs. We've been able to do that for a good year now. And we can go in, we have administrative rights to see, oh, how many open PCRs are out there. Some agencies are doing super well. And other agencies, it's an issue. So one, the PCR is not getting to the hospital. Two, it's not getting submitted for billing. So it's going to impact their revenue also. So we're looking at that. We are seeing some pretty good documentation, but obviously we are also seeing not so great documentation. So I'm speaking with our software program folks to have them come up and do, or at least do a Zoom meeting. Our projects besides the normal stuff of cardiac arrest, controlled substance administration, pediatric patients. I think that's it. We've also now added how much fluid they're getting for major trauma. So we've started to see that. Actually not a lot. So I think that's probably a good thing as long as it's not really needed. One of the things we're also adding this year is transporting to the most appropriate hospital. The interfacility transfer system is not 100%, as I know you guys know that. So it is important that patients go to the right hospital. And don't necessarily come to the closest hospital if they've got a trauma or something, and they really should go to, CBPH or somewhere else. So we are looking at that as a study this year. Tiffany sent me, and I also had a chart from Dr. Viola on services that different hospitals have. The agencies have received that, so they know, well, maybe if broken hip, definitely shouldn't go to E-Town, things like that. So hopefully that will help that whole process. We've also recently talked about, we had a transport of a patient who had a DNR and then went to cardiac arrest during the transport, and what to do with that patient. And the right thing was actually done. They went back to the sending facility, and that went well. So that doesn't happen obviously very often, but we did do that as a study this last round. And we are seeing the same thing you guys are seeing, where the patient doesn't have documented vitals prior to getting into the ambulance. So that is another function that we're going to be looking at. That will probably actually be brought up. We have a meeting on Thursday. Our QA/QI and CMEs so every month with our quarterly QA/QI, our CMEs, the hospital offers CMEs, and we do that all Zoom. We don't require them to come in anywhere. They can be sitting on their couch in their pajamas with hot cocoa or whatnot, but it seems to really help with the attendance, and it seems to be going pretty well. Spelling grammar. I think that's it.
Cool. Thank you.
You're welcome.
Hey,
Dr.
Tiff, I think we
Williams.
should have a quick formal approval of the renewals. I think we may
Oh
have missed
gosh,
it.
thank you.
Sorry. Yeah.
No, don't be. Thank you very much. I'm cruising right through the agenda and I missed that entirely. May I have a motion to approve the 2-year renewals? Thanks, Doug.
Okay, got it. I'll make a motion.
Okay,
I'll second it.
thank you. Any discussion?
Yeah, Tiff, it's John. Can you help me understand, and I'm sure there's some contractual or something, how in 12 months Saranac has one run? I'm just trying to understand what that means exactly.
Well, it is what it is. They are, they consider themselves sort of a backup service for the area. They're not the first call. Morrisonville and Dannemora are really doing the calls for the Saranac area. Historically, there was some sharing between Saranac Fire and Dannemora, and now not so much. That said, I think Saranac only has 5 or 7 members at this point. So it's a dwindling service. I'm not sure how long they're going to stay in service. They're in compliance, and so they're existent, but at some point they're going to have to decide whether they're going to, step up or step back. That said, they have a couple members, there were former members that are coming back this year, and so they may become a more robust service. So I've been kind of letting them slide for a little while.
Okay, so it's being covered by others ostensibly, and somehow they got one in within a 12-month period. Okay, thanks.
Yeah, crazy, right? True though.
Yeah, odd for sure.
Yeah.
Not to cause issues. And Jonathan might know the answer to this. When I was setting up Essex County for service, we had to be able to do 1 ambulance call a month. Is that right? So just put that in your basket there, Tiffany, about that one.
It's PCR a month. So even if before Mary Ramo used to say, even if they take the ambulance out for training, to have them do a PCR kind of a thing.
Yeah,
I
you
will
could do a
remind them.
standby and it would count as your, if you did a standby, it would count as your ambulance call for the month. And
Right.
Saranac, I think, does enough with sports probably to get away with it. And that's probably how they make their 12 calls. They need a month or a year.
Yeah,
I
although
believe
it's
they had
not
a letter that
recorded
they
here.
submitted. Sorry, I believe they had a letter too that they submitted about their coverage that was in their renewal package that kind of talked about how they work it. So they do have a plan.
Yeah, I'm aware that they're slacking.
They're-
But
It's
they
really
also we have conversed about it, so
I need
it's not
some message
off my
here.
radar either.
She
But-
needs to get a
Even if they respond to the scene and they don't transport, there should be a PCR because they
Right.
are responding. They have people responding, they get their rigs out. I think this is more of a record keeping clerical issue.
Do we know who their software vendor is? Because this could be even a back end, something's just not wired right in their system.
I would dare to say that they are doing what Dannemora was doing for vendor.
Okay, we can dig into that on
I'm
our side.
looking right now.
Great. The last time I talked to somebody from there and we had sort of a shakedown discussion, they were, the answer was, well, we're transitioning to ePCR from paper. And I said, that's not acceptable. You need to have transitioned. And that was the last talk we had. So
Yeah, I think it's all kind of become disheveled since they separated from Dannemora, who was like the primary agency that, probably managed all their ePCRs.
They use
but-
Image Trend.
Do they? Okay.
That's an easy one to look into.
Very good. While you're looking, let's have Dr. Williams QA/QI. I just want to keep us moving forward here.
Not much to report. We're doing QA. We did our meeting, incorporating more educational components into this to try to improve attendance. So yeah, that's about it.
And did Dr. Laporte pop on or no Dr. Laporte?
I don't see him.
Whoa, Dr. Laporte. Okay. Vinny is here from the state, so let's listen to Vinny while we've got him, and then we can move on.
Everyone, can you hear me all right?
Yes.
All right. So just a couple updates. Obviously, part R of the budget's out. There'll be plenty of discussion over the next couple days at CMAX EMSCO, which start with committee meetings on Wednesday to really see what that looks like. Just a couple kind of points that I would like to hit is essential services back in the budget. This has been a big push. Buprenorphine administration's in there again. I know that's been in the past couple of years, and then expanding the ability of demonstration projects. So what that definition is, obviously more will come out this week, and we'll have a better idea what that looks like. But that's kind of the key, kind of big key points of the budget. Investigations are still ongoing. We are busier than ever, so trying to get those out in a timely manner. As well as full services. And then just a couple things that from the full service inspection side. The one thing we're kind of pushing out and asking is people review their policies and procedures. We tend to give anywhere between a 2-week to 30-day kind of heads up that we're coming. And we're still finding that policies and procedures are still extremely outdated, sometimes on the upwards of 15 years old since they've been reviewed or implemented. So just kind of a friendly reminder that the policies and procedures that are required by 821 there's 15 of them. Just keep an eye out on those. And, if you have a slow day at the office, just take a look at them. The other kind of big push coming from us is with new vehicles, making sure that when you're lettering the vehicle, it either matches what your operating certificate says or a DBA that has been filed, or you have to file a DBA. That is right in the regulation. We are seeing some issues with that. So if we can just kind of put it out ahead of time and kind of qualm any issues, that would be great. And then the last thing, we are still working towards the transition to a division. We have been told that we are a division, but what that looks like is still oncoming. So hopefully there'll be more information this week out in Troy. And that is all I have, unless there's any questions.
What's the policy to look at again for the policies and procedures?
So right in part 800, it's 821, and that is section P.
Thank you.
You're welcome.
P is in Paul.
Correct.
Okay, any questions for Vinny? I'm going to look back to QA/QI. I was wondering if anybody else had anything to discuss about IV fluid and trauma patients, a regional study topic, that some response from your QA committees. Are we doing well? Are we doing poorly? Did we study this or did we forget? I know Patty said that it sounded like we were doing well from her perspective. Did anybody else have something to talk about there?
Didn't Amanda send out something? Was that her who sent it out?
Yeah, a few months ago, yeah.
Amanda, did you get any responses?
I don't remember off the top of my head. I feel like I
Sounds
got
like
a
no.
few.
Okay.
but I can't
I think
remember if
initially
that
we
was
had
before the
very
last.
few responses, and they were mostly from Dr. Katz's agencies, if I remember correct.
Yeah, and I can't
and
remember
then,
if that was before the last meeting or not.
yeah, I'm not sure. And then, so this meeting though, we pulled EPCR data for it, so that was in the meeting materials rather than just relying on our QA/QI groups. So that was in there. I don't know if we looked at that too much, but
Okay. Do you want to share that screen for us?
I can pull it up. Yep. So I went back for the year, and of the year, there was only, I believe it was around 200, if I get down to the criteria. So we limited just to emergency responses, obviously, and then normal saline. And we took out any of the transports because that was quite a big difference. But there's only about 200 administrations through all of 2024 is how we ran it. So considering that in the call volume, it was relatively low. And then if we define it further, a lot of these pulled results, but that it didn't necessarily narrow it down to just specific traumas. So of those 200, a lot of them were still, breathing problems or other various related things that were given the IV solution. So.
All right. Yeah, it looks like a lot of that is really not pertinent to what we were to our question. What do you guys think about, and literally I'm asking, what do you guys think about taking one more run at this? Everybody fill out Amanda's quick questionnaire. We'll talk about it at the next meeting, see if this is something we need to do regional education on or not, and then let's move on. I feel like we've been sitting on this for 2 years and we've just never really taken a decent run at it. Or do you guys want to just drop it now and move on to something more interesting? What's your feel? I would love to see us do something as a group for QA so that we can actually talk about change in education, but we seem to not be embracing that.
Well,
So I
why
wonder
don't we, I would suggest we get an accounting of the vital signs being delayed, and because, how long is it being delayed? And it seems like there's a fairly consistent consensus that that's happening. And it seems to be relatively new. I would say I haven't heard a lot before, pockets of. So to me, it would be making sure that our providers understand vital signs are called vital for a reason, right? We've all learned that, just to make sure that is occurring on a regular routine basis, because that's the decision tree for so many things, is beginning with that.
Thanks, Sean. Anybody else have some opinion?
I do wonder if we are missing the boat along that same line. We have some that are relatively short transport times. Even if it's a traumatic injury, if the patient's hypotensive, they're not doing a blood pressure until they're en route. They don't have time to, either link up with ALS or get a line in and give, any significant amount of fluids. So there may be a link between, the missing data for IV, in relationship to vital signs not being timely.
Anybody else have a feeling for a regional study topic? Ben, you have any thoughts?
Calling me out, huh? No, I'm fine with vital signs. I don't have any other burning desires.
All right, let's switch to vital signs. My concern was we were giving too much IV fluid in the face of trauma. It sounds like that's not what we're feeling, so that's great. So let's move on to vital signs before we move the patient, right? Ideally at the scene before we move the patient, unless we have another reason. And if, I don't know if Amanda, you might be motivated to do another questionnaire for us and bring that back to us at the next REMAC, that would be lovely. But let's do that with all of our QA groups and see what we come back with for data. Or at least discussion, right? I don't know that we need to sit here and crunch numbers, but it would be great for us to have something in common to chat about as far as QA as a REMAC.
So the vital signs too, Dr. Bombard, are directly, how can I describe this? So trauma centers are required to record the first on scene prior to departure vital signs on all trauma patients in the registry, which gets reported out to the state and gets reported out to TQIP, which is a trauma quality improvement, as a data quality indicator. So, you know, a reviewer could look at the percentage of vital signs that aren't done on scene and you know, say to the hospital or say to the trauma center, why haven't you addressed this with your pre-hospital system? So this is definitely something that if we're seeing that has dramatically increased or decreased in compliance, that trauma centers would want to know is being addressed as well.
Cool.
I think
Yay,
that,
good for us. We're playing on the team. I like it.
not so much focusing on vitals on scene, but the time from the patient, like time of arrival at patient to the time of first set.
Yeah.
'Cause
It's,
some patients
I mean,
just
it's going to be hard to, not everybody's going to document like these were vital signs at the seat that, you know, before we move the patient and after we move the patient, it's going to be a little soft, but I agree. I think that looking at arrival to vital sign time is probably the way to go because you'd have some idea. That's good. All right.
And for an example, there's some that are like approaching the hour mark before
Yeah.
they're getting a set of vitals on a patient. And that's just absurd.
Yeah. Agree. Cool. All right, Zach, can you switch us back to the agenda? All right. Next thing, I bet you I know why you have your hand up though, maybe.
I bet you do.
Same reason I have my hand up, really. So the next thing we need to really get back to talking about is Tri-Lakes QA. It sounds like everybody else is doing their QA nicely. I've had multiple discussions with Dr. Laporte, who I was hoping would be here to talk about QA in the Tri-Lakes region. He promised me that he would be here at this meeting with a plan, and he is not. So that's disappointing. So, Vinny, if you're still on, this is something that I think we are going to want you to become involved with. And this is something that we've talked about as a REMAC in the past, is that the rest of the region is doing their QA faithfully and the Tri-Lakes area is not. And we need to figure out how to fix that. Besides Dr. Pond and I speaking with Dr. Laporte, which seems to be going nowhere.
I'm not really familiar because I'm newer here, and Alex tends to cover the Mountain Lakes region. But typically, what occurs, and this is from my time at the program agency, is that ties back to the deliverables for the REMSCO contract. Not saying that it shouldn't happen. So we would have to take a look at Article 30 to see specifically what it says in there, which I believe is quality improvement. But are you looking at it from a regional perspective or an agency perspective?
Sort of a micro-regional perspective. So the rest of our region has QA, sort of, I don't know how else to call it other than micro-regions, so divisions. Some of them are counties, some of them are just looser groups in the counties, but they're areas surrounding the hospitals. that do QA for groups of agencies. With the exception of the Tri-Lakes area, which has not had any leadership from their hospital in this for probably 7 years, something like that. Despite our best efforts to encourage them to do so. If we pull up, John, can you pull up that Article 30 link that I sent you and screen share it? If you look at Article 30, what it says is that each agency needs to do QA. They can do it as a group of agencies or they can do it as a single agency, but they need to have provider involvement. And it says that right in Article 30. Here, we're going to pull it up for you here.
Yeah, I couldn't remember off the top of my head.
So here it is, so that you don't have to remember. Because I couldn't either, and I just looked at this just before the meeting. The quality improvement program may be conducted independently or in collaboration with other services with the appropriate regional council, with an EMS program agency, with a hospital, or with another appropriate organization approved by the department. Such a program shall include a committee of at least 5 members, at least 3 of whom do not participate in the provision of care by the service. At least 1 member will be a physician. The others can be nurses or emergency medical technicians or advanced emergency medical technicians or other appropriately qualified allied health personnel. So the rest of our region is well and truly in compliance with this. The Tri-Lakes area is not. We need some help in encouraging them to do the right thing. And we need some help from the state because we as a region have taken many, many, many runs at this and we are failing.
Right. So
can you please help us?
From our perspective, we would handle this at the agency level while conducting full services, because that is one of the questions we do ask them is what is their quality assurance, quality improvement, practice program, whatever they have implemented looks like. And we also strongly encourage medical director oversight because ultimately they are practicing under the medical director, and this alleviates, and I use more rural agencies because limited staffing, but 1 person doing quality assurance plus running the agency, so on and so forth. So that's why we often ask the medical director or encourage them to get the medical director involved, just from a physician's perspective, to make sure that the care, medication administrations, controlled substances, so on and so forth, is appropriate. What I can do
it says here in section 3006 that 1 member shall be a physician.
Right.
Doesn't have to be their medical director, but they have to have a physician involved.
Right.
So
and it makes it easier for the medical director because the medical director is the one, especially in controlled substance agencies. The medical director is the one who is signing off on controlled substance administrations when they're doing the semi-annual reports and so on and so forth. So it does have to be a physician. It does tend to make it easier that it's the agency medical director. Now, that is understanding that not all medical directors are active, and I'm not specifically pointing out any of the physicians who are here on this meeting, but we do run into instances where agency medical directors are not very active in the EMS system, or they don't
I can
understand.
assure you that the medical directors that are here on this meeting are extremely active and are all doing the right thing for their agencies as far as QA goes.
And I
the
believe
physicians
that
are here at this
because
meeting are not the problem. The
No,
physicians
and I
that are here
believe
at this
that
meeting are
because they are.
unusually dedicated and very helpful. So we need you to help us with the physician that's not here at this meeting.
Yeah, so we will, I will speak with Alex. Like I said, he happens to be on vacation today and tomorrow, but I will speak with Alex and see if we can come up with a solution, whether that is, reaching out to those agencies and conducting the reviews and seeing if we can get them to involve their medical director. And then I will also speak with Ed to see from that perspective what we have to offer as far as kind of ensuring that quality assurance and quality improvement is being done, because it's a huge part in EMS and growing the system and ensuring that good care is being given. My initial thought
Absolutely agreed.
maybe, would it be easier to realign your regional quality assurance, quality improvement?
No, listen, I gotta say something, because we're not gonna have this discussion. We're not gonna kick this down the road for another 5 years. John, when did you leave as the director for Adirondack Health? Broderick.
2012, 2013,
Okay,
something.
so since 2012, we have not had quality assurance out of this facility, which is a receiving facility, and it's also a medical direction facility. So that is a huge problem. And the hospitals do have a responsibility if they're a receiving hospital. And I think that this is not an agency issue whatsoever. This is a hospital issue. And unless we're going to take medical control away from that facility, which I think actually REMAC can do, and I think that REMAC's chairman and program director could meet with this facility, but I think that this facility in the last year has been extremely aware of what their responsibility is and have just literally ignored it, as well as, I would say, I don't know how many medical directors they've had in the ED, John, since you left, but there's been at least, I don't know, I'm just going to throw out 10. So basically, I think REMAC has not done its job for the past 2012 on, and this needs to stop. I pitched a fit about this a year ago. We went through a new medical director and we're having the same conversation. So I think if he wants to get kicked to the state, then the state needs to come in and deal with this. This may be a deliverable from REMSCO, but REMSCO cannot deal with this.
Vince, I can send you a copy of the letter that we as a REMAC sent to the CEO of the hospital, trying to encourage this to happen. But I can also tell you that Michael and I have had sit down conversations with their ED director. We have had many phone calls with their ED director, and we're just hitting the wall here.
So just because I'm not super familiar with your region, as of yet, I'm learning more and more as I sit on these. So do the hospitals handle all quality assurance and the REMAC doesn't? Or what does that look like?
Our receiving hospitals traditionally from the beginning of REMAC's time have held the quality assurance, and in reality are the only medical directors that could really see what comes in, what is transmitted to come in, what is received are all the same, and they're the only facility that can do quality assurance. And I think anything else is absurd. So in this, we've had this discussion till we've turned blue. So I think, and I'll be quite frank, I have turned 2 things over in the last 5 years to the state, like being unable to get PCRs from other medical directors and agencies, and not being able to get a death certificate from a county medical. Well, they don't have a medical examiner. They've got a coroner's medical doc that's paid, and both of those were turned over to the state and nothing happened. So I to this day have not got the death certificate, and had multiple PCRs never turned over by medical directors in both verbal and written stuff. So, I don't want to be tagged with quality assurance for an agency that I'm supposed to do under REMAC if the state won't accept that as a responsibility to make sure that can happen. And this is just, this has been kicked down the line so far that, you know, as far as I'm concerned, I'm on record that we're not doing our job.
Well, what I can do is, Dr. Bombard, if you can send me that letter,
Absolutely.
and then, like I said, I'm not super familiar with your system, so it will take me a little bit to kind of learn that and speak with Alex to make sure we're on the same
That's okay.
page. But we could definitely look at it internally and from the quality assurance, quality improvement standpoint, and then even if we have to set something up offline in between this meeting and your next meeting to kind of discuss that, you know, be more than happy to facilitate that or figure out a means to do so.
Fantastic. Thank you so much.
For my own awareness, is there a list somewhere of what QA division or whatever you're calling it covers what agencies of sorts, or no?
I think John has.
I don't believe I ever got a copy of that. I just went off of what was discussed here.
Well, we can easily pull that for you and recreate it.
That would be really helpful for when I'm doing the QI initiative.
Okay. Why don't you just send a quick Canvas letter out to the REMAC docs, just reminding people to send you which agencies go with which. I can probably rough it out, but I'm not going to be perfect.
It's much simpler. Just ask the agencies who their medical directors are and where their QA is going.
I honestly, like, this is to do it from this direction is, you know, 6 email addresses as opposed to trying to canvas all those agencies. So it'd be probably pretty easy to just ask the docs who they have. But it's geographically intuitive, so it's not going to be a big deal. Okay. Zach, can you throw the agenda back up for me? There's a lot. Yeah. Thank you, sir. Do we have any new guidance from Air Medical? I didn't see a representative from either of those. Did anybody else?
No,
No,
sorry.
great.
No, we haven't. And we haven't actually gotten a usage report in a little bit. I'll reach out to Colleen
Okay.
and I can push that out to everybody once we get it.
Okay. I will give you this about Air Medical. We've been working with the dispatch centers from Essex, Franklin, and Clinton County to come up with a guideline for placing the helicopter on standby from the dispatch center at the same time that the ambulance is dispatched. So right now in Franklin and Clinton counties, you have to have an EMS provider actually on the scene before the dispatchers will concede to putting a helicopter on standby or even launching. We're trying to fix that so that there are at least a few circumstances where the dispatchers will place the helicopter on standby at the same time that they are dispatching the ambulance. For both LifeNet and UVM, the policy is that they actually will launch. They won't just stand by, but they'll do their weather check, they'll warm up the helicopter, and if they haven't received any more data, they will launch and start going toward the scene. So this actually takes the helicopter from being an unusable tool because they're 40 minutes away or an hour away from the scene to a perhaps usable tool. So that's a project ongoing. If you hear about it, I just didn't want you to hear about it second. I wanted you to hear about it first, but that's something that we're doing up there. Okay. Regional transport guidelines update. The guidelines are up and they're running, at least in a bunch of the agencies. I don't know about Tom, how your experience is down there, but we're doing well with them up here. Amanda's been helping me out a lot, making sure that the providers are actually finishing their education before they're out there practicing. So that's been really helpful. I really appreciate you for that. And Dakota has an update on the protocol app. Unfortunately, the regional apps are not functioning right now, but he's got a Muru alliance, which has been going pretty well, it sounds like. So I'm going to hand it to Dakota.
Excuse me.
Bless you.
Thank you.
Or maybe I am.
You guys hear me now?
There you
Yep.
go.
Oh, there you go.
Yeah,
Hi.
there we go. Yeah, so am I able to share my screen at all? I'm not sure how to do that on Teams.
You should be able to, up by the leave button, there should be a share option.
Okay. So as I figured this out, I've had a couple meetings with the developers of Muru for the past couple of months. The issue that we're running into, and I just put it in the chat room too, so you guys can see that, is they found some issues with the language of how some of the protocols were written to put into the Muru app itself. However, I asked them to just basically ignore that for the time being so we can show essentially what we want in the app. The app is live, but currently I'm the only one that has access to it, so that doesn't help much. But with that being said, if I could get my computer to work, it is working just like the regular protocol searches would in Muru. If, for example, heparin, you type in heparin, it would bring up our exact interfacility protocol for heparin. It is functionable. They're just asking that before they push it live to the region that we fix the errors that they found in the guidelines that we adopted, which is why I put out in the chat. So as soon as that's done, they're live in the app.
My chat is not loading. Does anybody else have a loading problem? It may be just that my internet is not very great. But...
The last thing I see here in Lewis is from Dr. Broderick in the chat anyway.
It'd be 2 up from that. It's the first message Dakota sent.
I am chatless, so you guys are gonna have to tell me.
Okay, hold on, I'll click it.
Sorry.
See, it'll share.
Ooh, I see that.
Yeah, so that is the original document that we put together. And as you can see on the right-hand side, those are all of the comments that the developers from Muru said that they had questions about. A lot of this is like formulary stuff, which I don't know the answers to. So I told them that I would get back to them. I do have the master document that's editable. So once we get this figured out, I can edit, or whomever can edit and send back to them, and it's a matter of seconds for them to put it live.
Okay. In the interest of time, how about you send that out to Dr. Williams and Dr. Mulvey and Dr. Pond and I, and we will do an email response.
Okay.
And that should, and anybody else who wants it. I'm not trying to exclude anybody, but those were people that were kind of formers of these. And we'll take a look and give some guidance.
Perfect.
Awesome. Thank you so much. And thanks for all your hard work on this. I know that you've been kind of dogging this along, and that's really great. It was great that it wasn't me.
No problem.
And you're doing a nice job.
Thank you.
All right. Okay. Can we pop the agenda back up one more time, Zach? I think we're almost there.
Real quick, I just want to tell everybody that the reason why there is no regional protocol app right now is because your program agencies all don't have a contract with the state at this time. So that is funding that we would typically use out of our budget to pay for. But currently, we're going on. Well, contracts were supposed to go into effect July 1st. I'm not going to do the math for how many months. So like we've accumulated that much debt already, and we don't even have award letters for our contract yet. So we are not paying for things until we know we're gonna get paid.
Yeah.
Our goal is once the contracts are issued and we know that that money is coming, then we will revisit the other protocol app that most people seem to prefer over the Muru app and go from there.
Cool. Sorry.
Is that the old Mountain Lakes app?
The collaborative protocol.
Yes, what Zach said.
All right. New business. Remsco report, Dr. Pond and Patty.
So, we are having a meeting, well, we're having an informational meeting tonight because we don't have a quorum. But I felt it was important to, speak about what's been going on the Remsco side of the house. So that, you guys will, as we try to move forward, with an uncertain plan at this point, that, you'll understand why we're doing what we're doing. So let me just back up and briefly, I don't want to get into the weeds too much, but financially, we have not had a contract with the state since 2019, correct? 2019. So what does that mean? So the program agency, and Jonathan, correct me if I'm wrong, it's how much do you guys get? Is it 250,000? Or how much do you guys get from the state on the program side?
Around 250. I think it's a little
So-
bit more, and we are supposedly getting an increase, but we don't know.
Right, so the program side, which takes care of this right here and some deliverables and what Amanda's doing, that's solid. We're getting that done, obviously with the help of FDRHPO. So that's being said. What we don't have a contract for is it's around $25,000 a year, and we haven't received that for a few years now. Basically, the underlying reason is that we have things that we can't pull together to get an audit done or plug in for the state reports so that we can get those contract deliverables, that information to the state so that we can get paid for the contract. Because we haven't had one in a few years, we haven't gotten a contract with the state each year after that. So right now, our only income that we're getting, and Storm, please correct me if I'm wrong, is the CPR money, the bridge, the payment for the practicals of the bridge from CC to paramedic. Am I missing anything?
That's it.
So that's our,
Sources of
that,
funding we have.
that's, you're right, so that's our only funding that we have coming in. So, so with that being said, we haven't, because we can't get our taxes done, because we don't have all the paperwork to get that plugged in. We haven't gotten our, we've lost our char filing, something we need to have for the state to have a contract. So it's like a trickle down effect. With all this happening, we have been brainstorming, but not have come to a final decision, What do we do going forward? It is our intention of a committee that I had set up that has met a few times now to try to pull together as much information to meet each year financial information so that we can send in an someone say that for me.
Attestation.
Thank you.
Attestation.
To the state saying, here's our best information that we can give you, and draw a line in the sand and start moving forward. So we have two, in my mind, being the chair of the council now, I have two objectives. One is to try to go backwards and see what we can pull together. And two, try to move forward and figure out what we want to do moving forward. Does that mean that we also combine our two councils with North Country Council and our council? That has some positive parts to it. I know there are some concerns from others about it. Like, do we keep our own autonomy and so on? The initial, not well, I'll say the initial plan on the North Country side, the presentation that they gave us was, we just have our same representation on the council side, so we still have 30 people?
We have 20.
We have 20, so we still have 20 people. The REMAC could merge with that REMAC up there or stay separate and function separately, just like what you guys are doing now. So I just didn't want this to be a huge surprise when all of a sudden things started flying around, or you're hearing, like I just got a message from one of my own EMTs, well, I thought Mountain Lakes had gone away. Nope, there's the doctors up there still plugging along. So I wanted to make sure that if you start hearing things, you have some indication of what may happen in the future. And obviously it's my intention to keep you guys updated and get input. And Dr. Pond actually sat in our last meeting, which was super great, and gave input. So, you know, we want to make sure that you guys are aware of what's going on. And I'll take any questions. Jonathan, did I hit that pretty well?
Yeah.
Okay, that's all I had as far as that goes. And we have we're going to cover this at our Remsco meeting tonight. And, you know, we don't have a quorum, but so we're gonna, you know, I need to find out some things from some of the council members. We have some council or some counties that need to, put in some new, candidates because their candidates their term has expired. So we need to kind of, you know, get a handle on it so that we can have a quorum. That would be great, huh? So any questions for me on that? Dr. Pond, did you have anything?
Nope, that's fine. But I'm not,
Thank you.
I don't think I need to add anything.
Okay. Public comment? And anybody with a motion to adjourn?
A motion to adjourn.
Okay, and a second?
Second.
Thank you, everyone. Have a good night.